So Sandra from Melbourne's written in. She's had a colonoscopic evaluation of the bowel and she's been found to have polyps. So it would be interesting for me to ask Sandra what sort of feedback she had from the doctor that did the procedure. Were the polyps small? Were they large? Were there multiple polyps? It's probably important for her to know that polyps are quite common. So about 30 to 40% of people from the age of 50 have bowel polyps. And we think of bowel polyps as little lumps of tissue that are growing inside the intestine. Polyps can grow elsewhere in the human body. People are probably very familiar with the term nasal polyps. Polyps can grow in the womb. They can grow in the human bladder. They can grow in the gallbladder. They grow in lots of different places, and they have different significances depending on where they're grown. So 30 to 40% of people over the age of 50 will have a polyp in their colon, and generally they won't know they've got the polyp in their colon. A little lump of tissue that's growing. And the thing about polyps is that we've realised that all bowel cancers, or almost all bowel cancers, arise from polyps. So most polyps do not become cancers. About 5% of polyps have a malignant, a cancerous sort of part of them, but most polyps, fortunately, don't become cancerous. But you can't tell whether the polyp's going to become cancerous or not going to become cancerous in general when you find one during colonoscopy. So the general rule amongst gastroenterologists is just to remove every polyp and then retrieve them and have them analysed carefully, and that gives us a sense of satisfying that patient's risk going forward. So polyps are lumps of tissue. We remove them with a special device during colonoscopy and we have them analysed. They are a little bit more common in regard to previous family history. So there's a genetic basis for why polyps form. You're much more likely to have a polyp if your parents, brother or sister, have had polyps. So it's quite important if you're just thinking about whether I should have a colonoscopy or not have a colonoscopy, just knowing your family history. Do I have a family history of bowel cancer? Very important to have a test. Do I have a history of bowel polyps? There's probably a slightly increased risk of forming polyps as well if you're inclined to eat meats, particularly barbecued meats, very energy-dense foods, processed foods. The alcohol, unfortunately, can also promote polyp formation, whereas the Mediterranean diet tends to be somewhat protective against polyp formation.
So once you get a polyp, they remove them, but what if there's one cancerous? What do you do about it?
Yeah, so we remove all polyps when we find them at colonoscopy. And if we find a polyp that we're a little suspicious of, and that suspicion turns out to prove that it is cancer, then there's a whole range of things that we then do. We have a talk with the histopathologist, the person analysing the polyp under the microscope, about whether that malignant core of the polyp was completely clear of any vascular or lymphatic channels. These are drainage channels of the polyp. We also like to know how close the resection margin was to the little core of malignant cells. And this helps determine whether we can just be satisfied that we've removed it and cured the patient completely, or whether we have to talk with one of our surgical colleagues and then promote the patient for a surgical procedure to have wedge of tissue removed.
Can you describe, so you get the endoscope and, you got little scissors on it, I guess. Does it track where it is in the
So during a procedure, we know when we're doing the procedure fairly well where we are inside the colon. And we know where the various flexures are, the flexure points, the splenic flexure, the hepatic flexure near the spleen, near the liver. If we find a polyp that we think is of interest, it's a large polyp, perhaps it's flat. Some polyps are pedunculated. They're like mushrooms. They're quite easy to remove because of that little pedicle. Some are flatter. They're a bit like limpets hanging on a rock, and we have a very special technique for removing that sort of polyp. We inject liquid underneath it. We lift it up on a pillow of liquid, and then we can safely remove it. We use electrical current, so we don't like to burn through the bowel wall. Of course, that's a complication. We really prefer to avoid perforation. So we have this technique for lifting up the polyp on a bed of liquid, and we generally will put a little tattoo, Indian ink tattoo. So this is a way of us knowing exactly where that polyp was. Sometimes we might use a little metal clip. Metal clips are designed to bring the tissue fragments together so we can prevent bleeding, and that those metal clips do fall off over a period of weeks. But by that stage, we will have had the analysis back, and if it turns out that the polyp was malignant and we perhaps do need to do a bit more, we've got the clip there as a marker of where we were, or we have the Indian ink tattoo. And we'll come back generally in a year or a little longer, a little bit shorter, depending on the findings of the polyp analysis by the histopathologist, and then we can identify exactly where we were. So it's a very nice way of being able to get back to where you were and to examine that hot spot, if you like.
So can you describe, because I may have watched the things about the equipment.
So I'm sure Sandra probably didn't see the colonoscope or didn't want to see the colonoscope, but the colonoscope is a beautiful device, and it's a long, flexible tube, a bit over 1 metre long. And it can move in every direction. So we've got great manoeuvrability. We can really look around corners and find our way through even a very tortuous and difficult colon. There's a very powerful light source on the end, so we've got beautiful lighting up of this dark tunnel inside you. And we have a video chip on the end, which is taking images back through a processor. So we're looking at the internal workings of the bowel in magnification on an image. It's really tremendous. Then we have the ability to inflate the bowel, either with air or with carbon dioxide. We prefer carbon dioxide because it's rapidly absorbed and it's a bit safer for the patient. Air can cause a bit of distension and pain after the procedure. So we use insufflation. We have a little way of washing the end of the lens, very cleverly made. And then there's a channel, a working channel. Through that channel, we can pass a little catheter with a snare on the end. And the catheter at the human end is attached, in some cases, to an electrocautery device. Sometimes we don't need electrocautery. We can do cold removal of polyps. So we just sort of guillotine the polyp around. But the snare is a little metal loop. We can put current through it, or we don't have to put current through it. And we put that around the polyp, and then we gradually tighten that loose, and we remove that polyp. Sometimes in piecemeal. Sometimes we have to do it in piecemeal by lifting up the polyp on a bed of liquid.
So when you said a bit fast, the electro,
yeah.
So to describe how we're running electricity,
to
cauterize.
Yeah.
So we don't use knives.
Yeah.
Electricity will cut it.
Yes.
And then
sear
it so it doesn't
yes.
bleed anymore. So I presume that's how it works. But if you could just
somewhat so. So we have with the snare, we have the ability to remove the polyp without passing any electrical current, any heat. Electrical current down through that snare. That's called a cold snare removal. And this is really the preferred technique for polyps that are about 1 centimetre or smaller in size. Preferred because there's less bleeding actually using a cold snare technique. Blood vessels constrict and the natural processes of coagulation cut in. But for bigger polyps, or polyps with very big stalks, if they're a pedunculated polyp, we'll usually use electrical current, and that allows us to thermally remove the polyp from the bowel wall, prise it off. And then we can use clips to bring the surface of the bowel together to seal it. Clips are like metal sutures, really, and they're a wonderful device. They fall off 2 or 3 weeks down the track, and by which stage healing has taken place. It's very important before people have these procedures too that they reveal what medications they're taking to the doctor, if they're on blood thinners, anticoagulants, and there's lots of anticoagulants from aspirin and other aspirin-like molecules through to warfarin, which has been around for a long, long time, to some newer acting anticoagulants, and these have all sorts of important implications for us when we're doing procedures, because the bleeding risk goes up significantly if we haven't stopped those medications before doing the procedures. And sometimes we don't need to stop those anticoagulants, but other times we do. So it's very important we understand that. It's also very important we know if patients are diabetic, we don't want them fasting for the procedure. Fasting means no eating or drinking, and then they've taken their insulin on the morning of the procedure and they're fasting, they may become hypoglycemic. So we really want to know their medications. I think every patient should have a really detailed list, good understanding of what medications they've been given by their doctor. But it's very important prior to any procedure to know that.
How big are these clips? Are they like...
They're about the clips. The clips that we use are beautifully designed metal clips. They're about 3/4 the length of a match, and about that kind of thickness. And they're applied to the lining of the tissue to bring it together, so we get good control of the resection site, good healing, and they fall off 2-3 weeks, sometimes longer. Most patients are a little bit anxious that they're going to feel something stick in their bottom, but that doesn't happen. I can assure them they won't even hear a chink in the toilet bowl. It just gets passed out. It just gets passed out and without any concerns. It's also important for Sandra to know that once you've had a polyp, there's a chance that you will form another polyp. It's something like 30 to 40% chance over the next 5 years you'll form another polyp. And That's called a metachronous polyp. So it's important that we follow Sandra up, and the government has some very specific guidelines that were brought in November 2019 about our surveillance protocols. And in general, we try to stick to these protocols. There are some nuances that we have to discuss with patients and general practitioner, but in general, we follow those protocols. So it's very important that Sandra recognise, yes, the polyps have been removed. Hopefully she got very favourable results back from the laboratory, but she needs to be checked again.